Hi, I'm Pippa Grainger from the Diagnostic Genetics Department at LabPLUS. LabPLUS is the tertiary referral medical laboratory for the Auckland City Hospital and a major referral laboratory for specialised laboratory tests for New Zealand and the Pacific Islands. In the Diagnostic Genetics Department, we have teams working on pre-processing, cytogenetics, FISH, molecular hematology, molecular oncology, molecular genetics, and microarray. Within our molecular teams, due to the expanding number of variants for curation and the increased time pressure to perform these curations, we have been looking for a literature searching tool that could give clarity to our complex and rare variants and reduce the time it took scrolling through the literature. We've decided to investigate Mastermind due to the sheer number of variants recorded, full text articles indexed, and supplementary datasets indexed. Also, this is updated weekly rather than quarterly. We acquired our license in January 2021 and have implemented Mastermind searching as a standard practice for our constitutional SNVs and CMVs, with the somatic variants to come later in the year. In this presentation, I will take you through two cases in which we have used Mastermind. One was an SMV and one was a CMV. In the first case, we received a request for a targeted sequencing of the familial KCNQ1 variant in a 44-year-old male with a clinical diagnosis of long QT syndrome. On returning a positive heterozygous sequencing result, we curated the familial variant to confirm its relevance. We classify our variants according to the American College of Medical Genetics guidelines, which I will be referring to for this case. This case was a little tricky, as at first glance, we had only one moderate ACMG criteria that we could apply. Although it was a frameshift variant, resulting in a premature stop codon, it's only predicted to disrupt the last 45 amino acids and was less than 10% of the protein, and it's not within a recognized protein domain. This variant has been associated with multiple cases of long QT syndrome in a homozygous or compound heterozygous state, and there are 15 heterozygous variants found in the NOMAD population database. As we only had one moderate criteria using the ACMG guidelines, we needed to find at least one strong to be able to call this variant a class 4, likely pathogenic or higher. We were unable to use PS4 due to the number of heterozygous carriers within the NOMAD database, and so we needed to find a functional study. Using our previous software, we found 5 articles covering phenotype and cohort studies, but no functional studies. Using the Mastermind software, we were able to identify 23 papers, including a functional study, that were relevant to our search terms. And within this list of papers, which are sorted by relevance, the second hit was a January 2021 functional study illustrating the recessive inheritance pattern of this variant and the molecular mechanisms of disease. The data is even more impressive, as this variant was curated in February. We are able to apply a strong and moderate criteria, giving us a likely pathogenic variant. This case was reported as a heterozygous carrier for the familial class 4 variant. Due to the recessive nature of the inheritance and no other pathogenic variants identified within this family, further investigation was suggested. The clinical feedback was that they no longer believed this variant to be the cause of disease within the family, and family members who had previously tested negative for the variant were now being clinically monitored. Our second case was a prenatal amniotic fluid, which was referred for polyhydramnios, bilateral pleural effusions, and prenatal edema, referred to at 28 weeks. In this case, the microarray results showed 2 clear deletions at both ends of the chromosome 10, suggestive of a ring chromosome. The 2 regions contained many genes, and according to our standard cytogenetics guidelines, both regions were analyzed separately. We were able to copy and paste the coordinates straight from CHAS, our analysis software, directly into Mastermind. as you can see here. From sorting the overlapping tab and looking for the percentage overlap, we were able to obtain a hit containing the same genes as our copy number variant with a 90% overlap and a link out to the key papers. If you can see here, there were 2 papers that combined the region of interest, and the search also identified several intersecting and surrounding CMVs reported in the literature. By clicking on the titles on the side, it shows you the specific mention within the text for the variant of interest, and it allows us to quickly determine whether the papers are of interest or not. These journal articles were used to create the final clinical report. The beauty of Mastermind is that it can search our exact copy number regions using the coordinates straight from the software, efficiently finding the closest match to our CMVs in the literature to the nearest base pair with the same gene content. This does not seem to be possible with other search engines or curated databases. It is also able to filter out for specific papers of interest, such as functional studies, cohorts, although this was not required for this presentation, as in case 1, we were able to get a great number of papers on the original search. The other fantastic thing about Mastermind is their quick responses from their support people and the availability to speak to someone via a video call to go through difficult cases or run training sessions with our teams, with great feedback on how we could improve our searches or what's coming up in the quarterly updates. And I'd like to take a moment to just thank the Mastermind team for all of their great help and support, and my team at Diagnostic Genetics, with specific reference to Jasmine Jang and Natasha Hendon for supplying me with the details for case 1, and Elaine Doherty for supplying me with the details for case 2. Thank you very much.